express his issue and concern. He enlisted some additional support in that. But when he attacked the community, he started attacking the community because the community, interestingly enough, came out and supported the organization. So when this individual attacked the community, we banned him. And so that created a whole other firestorm. We have only banned 3 individuals from our site, and they're all related to this one individual. We allowed discussion, we allowed conversation, but when he attacked the community, that's where we drew the line. We have an etiquette policy set up. We also have an overall policy for use of Facebook within our organization. I think, you know, those kinds of things we address right away. We allow it. When it gets abusive, we eliminate it. There have been other issues where the patient care issues that we have addressed within 24 to 48 hours on our response, and for the most part have been thanked for getting back. I think some people are actually surprised that we respond to them in a very, you know, a very matter-of-fact way and say, you know, we understand your issue. We will talk to the right person. We will respond to you, or we will give them a connect point offline that they can go and talk to and resolve their issue. So I think it's worked reasonably well for us, and I think having that experience right out of the blocks really helped us understand what we were getting into from the beginning, because I know so many hospitals and providers out there struggle with, do they want to participate in this environment or not? And I think, you know, bottom line is, you know, the world's not going to end if you do. There are ways to figure this out, just like you would with any customer service or relationship management approach in your organization.
And did that guy go on to work for JetBlue, going down slides and stuff?
No, this individual really took his cause, and he was arrested several times in a variety of cities. So it's a whole long story I'm not going to get into, but I think we took the high road, and I think it worked out to our advantage.
Can I answer that question from the perspective of a personal blogger?
Sure.
You know, I don't blog a lot. I tend to blog when I have something to write about or something moves me to, which is one of the nice things about blogging. But certainly anybody who puts his or her opinion out on a website that's established is looking for trouble. Because there are people out there who will not like what you say and will argue with you, and there are people out there who are crazy and will simply attack you viciously, and perhaps get other people to attack you viciously. This is something that you have to have a little bit of a hard skin to be, I think, in the social media game of any kind, because you're making yourself vulnerable. I personally have stopped blogging pretty much for websites that don't moderate their comments, and the reason is that in my experience, anyways, is that when the crazies take over, the really meaningful comments that I'm trying to get a dialogue. I'm trying to get a conversation happening, and I welcome feedback. And anybody who's seen my blogs, I tend to write to the commenters, you know, and say that's a great thought, but I don't agree with you or whatever. But when the crazies take over, that stops, right? And all you get are the people who are going or have some wacko opinion or simply want to criticize me. And I think it's a social effect. So one of the things about my blogging is I just want to blog where there's some screen, somebody's actually looking at it, not to censor it, because I love negative comments. I just don't want people to say things that are totally inane or stupid or not about the topic.
Okay, great. Well, let me just take a minute so that everyone knows the panelists, if anyone arrived late. David Kibbe, with Senior Advisor with the American Academy of Family Physicians, blogs with Healthcare Blog and Kaiser Health News. John Sharp, next to David, is Manager of Research Informatics for Cleveland Clinic. Has been in social media for a long time, very well-followed blogger. And on the end of the panel there, John Marzano, who is the Vice President and Chief Communications Officer for Orlando Health, our host city right here. So again, panelists, thanks a lot for being here. Let's go on to some other questions. What are the opportunities and threats to the provider? And I'm thinking here of the provider both in terms of the organization and to individual stakeholder groups within those organizations as you look at social media.
you say again? The
Opportunities and threats.
Threats.
Yeah.
Well, I think there are more opportunities than threats, fortunately, otherwise we wouldn't be doing this panel. Well, I think that we talk about participatory medicine, patient engagement. I think there's a lot of potential there. We're still understanding how to do that and how to get that dialogue going. I think there's also a lot of opportunity both in education of medical professionals, whether that's your medical school or nursing or whatever, and just interactions within among providers. I think in the future, whenever a new program is proposed, I think social media has to be considered as part of that. You know, how are you going to? Is there an opportunity here to use social media in a new program or an existing program, and how could it be integrated if you're already having some interaction, such as between medical professionals, and especially in a large organization like ours, which is now, you know, in multiple states and multiple countries. It just makes sense, you know, to find ways to interact. But because there's some threats to that as well, and there was discussion earlier too about discussion among providers particularly, and the need to do that in a secure setting. So again, you have to choose to minimize the threats, and especially make providers comfortable in sharing information about interesting cases or difficult cases. That sometimes has to be done in a more secure type of site, rather than in the more public ones that we're familiar with.
Yeah, I think as I mentioned earlier about this being another tactic when it comes to the whole marketing and communications function. To me, it's about brand awareness and preference, and engaging audiences in another way. Communicating with them and looking to build your brand through another medium. And in our case, if traditional media is going by the boards because of the economy, then we have to figure out a way to tell our story. Not through the mainstream media, but through this. And this is an opportunity we can control and manage it. I think the threat is you're always going to be exposed if you have a messy PR situation that you've got to deal with. I think as an organization, the expectation is you're going to be transparent to a point, but this will force you, I think, to be completely transparent, because your audience will tell you if you're not coming clean with it. And so you always have to be aware of that. The other piece is, I think if you're not involved, you're falling behind. This seems to be the future. Again, right now, this whole medium is going to evolve. I'm sure just like the internet has evolved over the years. So I think we have to be out there looking at what's new and exciting, to engage our community and our audiences. And that's sort of the way we look at it. That's great.
Can I mention one opportunity that is very important to me and I'm very hopeful about? And that is to help providers communicate with one another in real time in the process of patient care. I'm old enough to remember that when I was in private practice in the 1980s, as a primary care doc, I had my cardiologist and my gastroenterologist who helped me take care of patients. And I saw them almost every day because I took care of patients in the hospital, right? And I was in a community that was small enough that we shared a number of venues. Most primary care physicians don't take care of their patients in the hospital anymore. Our social environment as physicians, I think, has become very impoverished one to another. Some of you may have heard that we're partnering with SureScripts to do what we're calling AAFP Physicians Direct, which is hopefully the start of that. It's a way of clinical messaging securely and affordably between the primary care physician and the specialist. But you could see that becoming more like Facebook in the sense of multiple conversations taking place among the care team for a particularly difficult patient or a patient who's dying, and a way of coordinating the care and making sure that all of the people, not just doctors, but the nurses and the caregivers in the home are on the same page. And so I'm really hopeful that we'll use the technology in that way in the coming years. We already have the technology to do that. That's not the problem. That's not the barrier to doing it this way. And in some places, like the Cleveland Clinic, they're already doing it. But in large organizations, it's easier, I think, to do that than it is in communities where the physicians may be part of different organizations and where the home care entity is a different organization altogether.
Can I have one other?
Yeah, sure.
One other example that we're doing is using social media, particularly Twitter, for educational sessions, particularly public lecture type situations, or even within CME, and set up a hashtag for that, and people give this series of lectures called Cleveland Clinic Ideas.
Very short lectures, right?
No, these are hours, but these are big folks. These are heavy hitters that often come in to speak. But anyway, they're and what the communications folks have done is actually invite a panel of tweeters from the community and me, and to do live tweeting during the event, and it really extends the reach of that event. I mean, it's a 1,000-person, 1,000-seat auditorium, but the reach beyond that is huge because a lot of people, the 1,500 of my closest friends on Twitter hear about it, as well as other people, friends of these other Twitter people too. So it's an interesting way to extend the reach and to, I think, promote the brand.
So it kind of goes right in the follow-up question in terms of what other kinds of innovations have you seen or are you beginning to experiment with that you think are of interest potentially?
There's one other I was going to mention. I don't want to hog them, so just shut me up. But our marketing people came up with this great campaign called Let's Move It. And it's a combination of a video, a mobile app, and a opportunity to submit videos, and then a tie-in with the local sports teams to get people up and moving. And the idea is you can submit your video showing yourself exercising, and people do crazy, they'll do push-ups with their baby on their back, and I don't know what else, fun stuff. And then they can also ask questions that are then answered by one of our physicians along with somebody from one of the sports teams. So it's a whole tie-in around local sports teams as well as wellness, exercise, and the whole thing. And it's been pretty successful, at least in Northeast Ohio.
One of the things we've just done recently with, resources are always tight and marketing is always the one, sort of the low-hanging fruit when times get tough. So for our Arnold Palmer Hospital campaign, we put out a call for, the campaign's tagged Meet Our Kids. And we put out a call through our sites that send us or upload a photo of your child, any age, or a video, and we're pulling those in and using that as a campaign commercial. So we're showcasing a number of those kids, whether it's on our TV spots, in our print ads, or microsites, and it's really saved us a lot of money in production. So, there are different ways of using that, I think, and we're just scratching the surface of the possibilities here. And I think we've had, last count, I think it was over 300 pictures that were uploaded for this campaign, and we're going to start using those, and we continue to do this and grab pictures as this campaign's going to run. So really fun, interesting stuff, but it's a little unique, a little different, but at the end it's saving us a little bit of money.
You also had, last time we talked, you talked about some innovations you've done with the Winnie Palmer website as well.
Yeah, one of the things, Winnie Palmer Hospital is known throughout this region as sort of the baby factory. I think at its height It did, 2 years ago, it did 15,000 births. I think it's the second busiest birthing facility in the country. It's got fantastic ratings, just a wonderful facility. But we wanted to extend that service beyond just OB and go into GYN and other women's health issues. So we launched a microsite recently that is called accordingtowinnie.com. And in there we put videos about GYN surgery, hysterectomy, other things like that. And in a period of 3 months had 5,000 plus unique visitors to that site. And those visitors helped identify the top 3 videos that they viewed on there. One was hysterectomy, one was minimally invasive GYN surgery, and the third was urinary incontinence. So as we extend the According to Winnie campaign as a bridge to our women's health line, we're going to use, our patients, our customers out there are telling us what we should focus on taking that campaign forward. Those 3 areas are going to be part of the second phase of this campaign. So again, it's engaging people and it's responding to that direct response that they're giving us. So again, as we look at this tactically, we're just being open to new ways of doing this. And again, it's much more targeted than any research we could do, because these are actual people telling us this is what we want to hear.
That's terrific innovation. I think every time I hear these stories, I'm just amazed at the potential and the possibilities of what people are really doing. There's a great question that just got asked. There's been a big push now to get physicians to adopt enterprise IT. It's one of the reasons a lot of us are here, I guess. But are there similar struggles with social media in terms of getting physician and other healthcare provider adoption?
Well, I'll take that. I was a part of a conference a year and a half ago in Hawaii that was on telemedicine. And one of the stories around that conference was that Kaiser Health in Hawaii had decreased their face-to-face visits by 26% in 1 year by using email consultations with patients. And it was a true win-win. The patients loved it because they were getting contact with their physicians for a laboratory result instead of having to come in and see the doctor. And you can imagine the kinds of things that can be done with very simple, secure email communications with patients. The docs loved it because they weren't taking up their time with very small problems, and the administrator loved it because it went right to their bottom line, right? Now try going to Toledo, Ohio, as I have, and stand in front of a medical staff of doctors working in private practice and say, I have a way to decrease your face-to-face visits by 26%, right? And they throw apples at you in raw sewage because you're taking away their livelihood in a fee-for-service environment. And I think if there's one thing I have to remind people over and over again is that physicians in primary care who are reimbursed by fee-for-service are paid by the visit, and they're already stressed economically, right? So it's very hard to have them do the right thing when it is economically hurting them. So I think one of the issues there is that if we have payment reform, when we have payment reform, that allows providers to use the information technology to take better care of patients, but not cost them their salaries, we will see an explosion in social media because that allows us to close the collaboration gap.
Does anyone know the ICD-10 code for tweeting? Is that
consultation by tweet? Yeah.
It's still an issue, though, for provider. The other issue, besides anything that threatens reimbursement, is just pure time, and most physicians just don't see enough value yet to spend any time in it. There are exceptions, or physician bloggers, or others out there on Twitter, but it's still the exception rather than the rule, and most still oppose receiving patient emails. Again, there are exceptions, but having marketing people develop a campaign to help bring in more patients is a great thing. Any way they want to do it, you know, is usually fine with the physicians, or the physicians will actually come, you know, could we try this on Facebook or this on Twitter or this on YouTube? But to spend any time in it themselves just doesn't seem feasible.
All I was going to add is, from our standpoint, the more physician expert videos we produced and put on our sites, the more physicians called on us to include them. So I think it's one of those things that if they see it's non-threatening and they see their colleagues who are featured there and no one's coming and doing anything bad to them, I think they engage it. And we find that that's, you know, it's sort of peer pressure a little bit at that point in time. That, you know, they want to be a part of this as well.
Me too.
So we got a couple of questions via Twitter asking about, you know, what's your method for determining topics that you're going to cover, and you know, and what's the best way to disseminate and educate? What do you like in terms of topics and how you choose to get them out?
Well, I think we do I guess we call our top 6. It would be peds, OBGYN, women's, cardiac, cancer, ortho. I mean, generally those are the primary areas we would focus on. But we're not opposed to fun things. We'll do some fun things around Heart Month, for example, where we've got something on our sites now. In October, we did Pink October. We focused on breast cancer for the entire month, and we would use stories associated with that. So I think it's going to focus on the big ones most of the time, but we will incorporate a mix of other services that are unique to us, and that, again, we're going to drive business to the organization, because the bottom line is about driving a business more times than not.
I would say the same, primarily, although because we have some physicians in very minute subspecialties, they sometimes may want to do a physician chat or some kind of effort around social media to target those specific patients on a more national level. The other, I had another thought, but I'll come back to it.
Thanks. So now I've got an easy question for you, okay? What are the implications for the electronic health record? I mean, for example, the boundaries for what gets included in the medical record. And we've got, you know, 5 minutes to get this all resolved. So.
Don't go there. No, sorry. Well, I think that, well, you should answer. No. I think there may be opportunities for future integration. I think, you know, our stance is if a physician gets some kind of electronic communication from a patient, you know, an email or something that's unsecured, which is not ideal, that they will copy and paste that into a note so that it's documented. We haven't gone to one-to-one communication through any kind of social media yet, so I think that would be a problem. You know, there are a lot of legal issues around that, so it's a tricky one. And again, the more general approach to just giving medical information as opposed to medical advice to an individual, general medical information or guidance is very much different than saying, for your condition, you should do this over a public media, which is very dicey, I think, legally.
Well, you know, I started writing clinical groupware about 2 years ago, primarily because I didn't want to talk about EHRs anymore. You know, electronic health, and the federal government came along and said, okay, we'll call it electronic health record technology. We'll call it EHR technology, right? But, you know, I think the meaningful use rules and regulations are moving us towards clinical groupware. Stage 1 doesn't require a lot of exchange of health information, but it does require some. It doesn't require a lot of reaching out to the patient, both passively and actively, but it does require some. And I think in stage 2, we're going to see that medical practices will not be able to function without a patient portal. They won't be able to function unless they have a means of moving their data somewhere else, particularly outside their network, including to the providers that they refer to, and back, but also to their patients. And then thirdly, I think patient engagement as a component of meaningful use is going to move us further along the idea of participatory medicine, because it's going to require patient education that's specific to the information in the electronic health record. But I wish we could just stop talking about electronic health records altogether, because people have so many ideas about what this is, but it's not. And if we could come up with some satisfactory additional descriptor, it might be helpful.
Thanks. John, any closing comments? Great. Well, I think that has pretty much answered a lot of the questions that came up on Twitter. And with that, I'm going to thank our panel. I think they were just terrific. Thanks for coming.
Thank you.